Hi, I'm Abby from In the Mess. Today we're going to talk about interpreting a full blood count. A full blood count is one of the most frequently done tests in medical practice. It's a venous sample taken in EDTA, and it tests the cellular components of blood. Understanding and interpreting a full blood count can give you clues to underlying pathology and guide further testing. A modern full blood count is automated and you get rapid results within seconds. Cells are counted based on their size and complexity. To understand a full blood count, you need to know where blood comes from. Blood is made in your bone marrow from the hematopoietic stem cell. Broadly, this cell divides into two lineages, the myeloid and the lymphoid cells. Platelets and red blood cells come from the myeloid lineage, and white blood cells come from either the myeloid or lymphoid lineage. Neutrophils, basophils, and eosinophils come from the myeloid lineage, whereas B and T lymphocytes come from the lymphoid lineage. Before we look at the full blood count in a bit of detail, let's talk about some general tips. Firstly, when interpreting a full blood count, look at each cell in turn. Cell numbers can be high or they can be low. For example, a high hemoglobin means polycythemia, or a low hemoglobin level means anemia. Leukocytosis is high white count, while leukopenia is a low white count. Thrombocytosis means high platelet count, whereas thrombocytopenia means low platelets. Isolated abnormalities are very different to abnormalities affecting all three lineages. Take, for example, someone presenting with an isolated thrombocytopenia who might just have ITP or immune thrombocytopenia, compared to someone with thrombocytopenia, anemia, and leukopenia, or pancytopenia. This pancytopenia is worrying and might mean a bone marrow failure syndrome, secondary to leukemia. Secondly, never interpret a full blood count in isolation. It's always important to interpret this in the correct clinical context. A high white count in someone with a fever or cough is usually because of an infection. In someone with COPD who's recently had a course of steroids, will have a neutrophilia. A high white count doesn't always mean a primary bone marrow problem like leukemia. Pancytopenia, however, could mean that. It could also occur after chemotherapy and is an expected finding, and therefore usually doesn't require further investigation in this context. Thirdly, trends are generally more useful than isolated results. A hemoglobin drop from 140 to 90 over months usually suggests chronic pathology, compared to the same drop over days, which usually suggests an acute bleed. A hematologist's favourite test is a blood film and is an extremely valuable tool when interpreting a full blood count. Not only can it offer you a spot diagnosis, but can give you clues to further pathologies. Anyone can request a blood film. In order to interpret and provide meaningful reports from a blood film, it is important that we get useful clinical information. Therefore, requesting a blood count and a blood film with the phrase monitoring is inadequate. Moving on to the red blood cells in a bit more detail. The basic red blood cells tests include a hemoglobin concentration, a hematocrit, a reticulocyte count, and a mean corpuscular volume. A hemoglobin concentration can be high or low. A low hemoglobin means anemia. Hematocrit tells you how thick the blood is, and if it's high, it usually indicates polycythemia. Reticulocyte is a brand new red blood cell from the bone marrow, and it's usually bigger than a mature red cell. Mean corpuscular volume tells you how big the red blood cell is, and it can be small, normal, or large. A guide to anemia. A low hemoglobin means anemia, and once you've identified this, the next test to look for is the MCV. Microcytic or small red blood cells and anemia is usually caused because of iron deficiency anemia or a hemoglobinopathy such as sickle cell disease, a disorder of the red blood cell itself. Macrocytic or large red blood cells is usually secondary to low levels of vitamin B12 or folic acid. However, it could be because of hemolysis, where you have an increased number of reticulocytes produced as a compensation to the breakdown of your red blood cells. Normocytic anemia is in the middle and can be because of anemia of chronic disease, such as secondary to renal impairment, or because of bone marrow failure. You can have a normocytic anemia as a combination of large and small red cells averaged out to normal cells. Therefore, it's important to look at a blood film so you don't miss hematinic deficiencies. Polycythemia means a high hematocrit. This is defined as a value of more than 0.52 in men and more than 0.48 in women. It is usually not because of blood disorders, but is because of disorders such as alcohol excess, dehydration, smoking, and hypoxia. Moving on to the white blood cells. There are two values that you get, a total white count and a white count differential. The differential count breaks down the different subtypes of white blood cell and gives you a count for each of them. This includes a neutrophil count, which are the cells that help fight off bacterial infections, lymphocyte count, which are cells that usually help fight off viral infections, monocytes, which are tissue macrophages, eosinophils and basophils that help fight off allergic diseases and worms. It is important to look at the white count and the differential count. Take, for example, someone presenting with a white count of 120. This might be alarming at first. However, the differential here shows a neutrophil count of 10 and a lymphocyte count of 109. This usually suggests a chronic condition like CLL, or chronic lymphocytic leukemia. Take, for example, the other scenario, where you have someone with a white count that is entirely normal, but a differential count that's abnormal. In this example, the patient has a neutrophil count of 0.1, which is concerning because if this patient presented with a fever, they are at risk of severe life-threatening neutropenic infections. The white count is normal, however, because the machine analyzer has identified abnormal cells and counted them in a normal white cell population. These abnormal cells are actually blasts, and in this scenario would typically indicate acute myeloid leukemia or acute lymphoblastic leukemia. Moving on to platelets. You usually just get a platelet count, in which case you either have a thrombocytosis or a thrombocytopenia. Some full blood count analyzers also issue out a mean platelet volume, which tells you the size of a platelet. Thrombocytopenia, or a low platelet count, is broadly because of two large causes, either decreased production or increased destruction. Increased destruction is because of immune or non-immune causes. Examples of immune causes include ITP, or drug-induced thrombocytopenia, the most important of which is heparin-induced thrombocytopenia. Non-immune causes include conditions like DIC, which have been covered in another video. Moving on to the second cause, which is decreased production. This is usually because of bone marrow failure syndromes and can be acquired or congenital. For example, malignancy causing an acquired bone marrow failure syndrome, or congenital cause like Fanconi's anemia causing decreased production. An important cause of thrombocytopenia is actually artifactual. This occurs because of platelet clumping, where platelets stick together as a consequence of EDTA, triggering antibodies to be directed against the platelets. This can be readily identified with a blood film and is a reassuring finding. It is an in vitro phenomenon with no effect for the patient and can be ignored. Finally, thrombocytosis, or a high platelet count. Broadly, disorders can be classified as either reactive, or out with the bone marrow, or primary, or within the bone marrow. Most causes of thrombocytosis is reactive. This can be reactive secondary to anemia, i.e. blood loss, infectious diseases, malignancy, inflammatory conditions, or a post-operative state. Primary bone marrow conditions that lead to high platelet count include myeloproliferative neoplasms, such as ET or essential thrombocythemia. I hope you found that useful. If you did, please like, share, and subscribe.